Next, I'll welcome up Dr. Nish Panu to discuss clinical decision support for AKI. Are we there yet?
Okay, I'd like to just start by thanking Rabbi for the opportunity to speak here. It's always one of my favorite times of the year to see everybody here again. I'll try and keep you awake for the next 15 minutes. I have a few slides, so I will try and get through them as best I can. So the question is, are we there yet? So I thought I would just say a couple words just about leveraging the electronic health record for research. Just just a quick description of what I'm talking about when I'm talking about clinical decision support, how AKI is in some ways an ideal model, in other ways not, for testing the role of clinical decision support, and then current evidence in the area of AKI. So in terms of electronic health records and research, we've all been sort of intrigued by the promise of big data. Tons of, we have vital signs, we have lab data, we have diagnostic imaging, medications, in the future, maybe genomics and other things, clinical notes as well. How can we combine all of this to provide better care for our patients? We heard an earlier lecture today about learning health systems, and there's really been a lot of discussion about the promise and the hope of leveraging electronic health records to deliver that learning health system. When obviously some of the advantages of having these types of health records is the ability to capture longitudinal data and be able to intervene in real time. Ideally, it is cost effective to leverage these electronic health records, although some of us who do this work can say that it is costly both in terms of time, sometimes brain cells as well as dollars. But, it doesn't involve biomarkers or extra testing. It's really leveraging existing knowledge to be able to solve clinical questions. So there are lots of problems with big data, and so many of you who work in the room, I know work with big data, and you all know, structured data is one thing, so diagnostic codes, billing codes, medications, vital signs labs. And then there's the unstructured data, which very few of us have really tried to tackle. I think, many of us would think that probably most of the information, particularly in areas like social determinants of health, they all sit in that unstructured data. But that's a lot more difficult to get out of the electronic health record as opposed to structured data. In terms of challenges with doing this type of research, the heterogeneity of the data is a huge issue. Data fidelity is a problem. This isn't research data. There's no obvious mechanisms to audit or assess data quality. So the amount of work that's involved in doing that is not trivial. Missing data is a big issue. It's very hard to get, I hear all the time from my IT people, you need to get your doctors to fill out these forms, and we know that that is not an easy task. So the dimensionality and just the size of the data that we're working with are limitations. Some of the EHRs that we have deployed are really never designed for research, so trying to get valid information and trying to leverage that information can be challenging. So kind of switching gears to clinical decision support, what are we talking about? We're really talking about a computer program that should improve health delivery by enhancing medical decision making using patient information. So there are lots of different ways you can do this. You can generate alerts, and we'll talk a little bit about AKI alerts and where we're getting with that. Assisting in diagnosis, so making recommendations for testing. You can use them for planning therapy, providing treatment advice or guidelines, or for image recognition and interpretation, like in radiology. You really need three main components to set up a clinical decision support system. You need to have medical knowledge of the topic, you need to have patient data, and you need to have case-specific advice. And this is where it can be challenging in acute kidney injury, since we're really not dealing with a particular disease where it's a heterogeneous group of conditions it's really a clinical syndrome. And so providing case-specific advice requires specifically identifying the etiology often of these disorders. And so the limited success that we have with clinical decision support systems has been in situations where we have a specific diagnosis for the AKI. So in an ideal world, we'd be able to collect all this data in the electronic health record. We can create predictive models. We can, can't go back there. But anyways, leverage that to make enhance decision-making. There's really been an explosion in terms of digital health research in acute kidney injury. So this is a figure from one of our previous AKIs, but what you can see is that a lot of that explosion has been in the area of clinical decision support. That being said, we see very few of these clinical support tools really being deployed in clinical practice, and there's lots of reasons for that. So AKI theoretically is an ideal target outcome for these types of interventions. It's common, it's under-recognized, it's potentially avoidable, at least 20% is avoidable. And we can't, there are a limited number of nephrologists that can deal with all of the AKI out there, so being able to enhance an automated sort of process to identify or treat this condition would be perfect. The other thing is obviously it's a diagnosis that it's determined by lab values and time, so it really should be ideal in some respects to use this type of an approach. Most importantly, it's also associated with a host of adverse outcomes, both in the short and the long term. So kidney outcomes, hospital readmission, cardiovascular events, and mortality, as everybody in this room well knows. So, and finally, electronic health records do allow us to link whatever happens in the hospital in many situations, particularly in integrated health systems, to what happens outside of the hospital. And that's an area that my colleagues and I have sort of have been working in. That's a space that we've been working in. So does it work for AKI? Let's review a little bit of the data. So this is a randomized trial that was published by Perry Wilson. It's almost 10 years ago now. So this was a randomized trial of AKI alerts in a couple of thousand patients in the Yale Health System. And it was simply an alert. So when the primary outcome for this trial was a composite of an increase in creatinine, dialysis, and death. And as you can see, there was really no difference in outcomes between treatment groups. And in this particular situation, it was just an AKI alert. There was no decision-making or tools that were attached to the alert, simply an alert. So subsequently, a systematic review was done in 2017, which suggested that there was really no evidence that that a simple alert would be particularly effective with the outcomes of mortality, reduction in the use of renal replacement therapy or fluid therapy. A number of other studies were subsequently published, including this one from John Kellerman colleagues out of UPMC. This was not a randomized trial. This was a multi-center prospective study where they looked at pre-implementation, post-implementation of an electronic alert, and the intervention that they used is on the left-hand side there. So again, it is just simply alert that the patient had acute kidney injury. While they did not see any difference in mortality outcomes or with the intervention, they did see a signal in terms of length of stay and the use of renal replacement therapy in patients that did receive the alert. But again, this wasn't a randomized trial. This was a pre-post intervention. One area where we have shown that such an alert may be effective has been in the setting of nephrotoxic AKI, and everyone I'm sure in this room is very familiar with Stu Goldstein's work, which is this NINJA detection system. So again, just to really briefly summarize it, it was an EHR-based screening intervention to assess changes in AKI prevalence or duration, and really it was just signaling when patients were exposed to a number of nephrotoxins and providing that information to the frontline staff. And he was able to show both in a single center as well as in a multi-center deployment of this intervention that they were able to successfully reduce the incidence of acute kidney injury. But again, this isn't a specific situation. This is nephrotoxic AKI. It was being anticipated. Specific medications were targeted, and clusters of medication prescriptions would be the sort of the premise of the alert. This NINJA system has been successfully deployed in adults, but there has really been no reporting of whether it prevents acute kidney injury, although it does suggest that there is a significant amount of nephrotoxic acute kidney injury in adults. And I think this is an area for future, where I anticipate there will be future work by many groups, likely in this room, in terms of using such an alert for triggering an intervention, particularly in the nephrotoxic AKI group. So again, this was a study that I think was highlighted a little bit earlier today. This is Perry Wilson, another trial from Perry Wilson and his colleagues at Yale, and it was published in Nature Communications in 2023. And this was a randomized trial of clinical decision support identifying nephrotoxin exposure. And in this case, he really restricted it to 3 specific groups of nephrotoxins: NSAIDs, RAS inhibitors, and proton pump inhibitors, because he felt that those, they had decided a priori that those were likely, were likely causes of acute kidney injury. So in patients who were identified as having KDIGO-defined acute kidney injury, the alert would prompt providers to consider discontinuation of these medications. So there were 5,000 patients enrolled across 4 hospitals in this intervention. The primary outcome was a composite of progression of AKI to a higher KDIGO stage, dialysis, or death within 14 days, with pre-specified analyses for medication subgroupings. So I think, as was shown in previously, there was no difference in the overall outcome. However, there was a signal, particularly in the group that received proton pump inhibitors. So in patients who had their proton pump inhibitors deprescribed, that particular pre-specified analysis did reach significance. And you can see on the left the type of alert. So in this case, the alert was also associated with a specific intervention. And again, targeting nephrotoxic AKI as opposed to all AKI. So, the thing about e-alerts is that there are, pros and cons to these types of interventions. So there, obviously in a situation in AKI, which is frequently underdiagnosed, it can certainly improve recognition of acute kidney injury, and in providers that have limited information about alternative dosing in patients with diminished kidney function, you can imagine that those might be positive factors for using such an alerting system. But like all alerts, and we are probably, all of us who work in electronic health records know, alert fatigue is a major problem. Many of us, including myself, override alerts frequently. So you really have to, it's a balance between harassing people that are providing care and obtaining a benefit. And this is a well-known kind of paradox. So the more we know that the more invasive the alerting system, or the more invasive the clinical decision support system, the more effective it is, but it's also the more annoying. So whether these types of interventions fade over time is another question. This is one of the reasons that they're very difficult to deploy. So again, e-alerts coupled to an intervention, there is a suggestion that these types of things might be more successful. Although, again, it's a mixed bag. So this is another trial by Perry Wilson, where he essentially linked an AKI alert to an AKI order set. And this is similar work that we've done in our center as well. And this was a randomized trial that was done in a number of both teaching and non-teaching hospitals in Yale, and essentially with a composite outcome of progression of AKI, dialysis, and death. And again, there was no difference in the composite outcome, although there was actually a signal towards harm in the non-teaching hospitals, suggesting that just providing information without context and without a specific diagnosis, since this was all AKI as opposed to nephrotoxic AKI, that perhaps you can actually do harm with this type of an intervention, which was a bit of a wake-up call for those of us who work in this area. So Nick Selby's trial is also well known. This was a step wedge cluster randomized trial. He combined an AKI alert with an AKI care bundle. So in patients who received an AKI alert, they also received the AKI care bundle, which was an assessment of volume status, guidelines about treating sepsis, medication review, a urinalysis, and referral to nephrology if appropriate. He did not find a difference in 30-day mortality, but he did find that his intervention did improve recognition and decrease length of hospital stay, as well as a reduction in the duration of acute kidney injury. So another example of a successful intervention of an alert paired to an intervention is a study that was done in Alberta, where I'm from. Matt James from our group led this intervention, which is essentially, it was a multimodal interventional study to prevent acute kidney injury in the context of contrast-associated kidney injury in patients receiving coronary angiography. And as you can see, it was a pretty complex intervention that was embedded into the electronic health record, required a lot of tailoring and localization. And it was, again, and this is kind of it was the information that was provided to caregivers was very specific. So specific contrast limits, specific amounts of volume to be prescribed within the cath lab. So again, a specific etiology of AKI with a personalized prescription. And again, this was a positive trial. It was reported in JAMA in 2021. So in terms of ongoing EHR clinical decision support trials, I'm just wrapping up right now. There are a couple ongoing that there are probably, when I did a quick survey through clinicaltrials.gov, this is another one by Perry Wilson and his group at Yale, and this is the CAT AKI trial. And again, what he's doing in this trial, which is currently enrolling, is to use an electronic alert coupled to a kidney action team. So in this case, the alert is coupled to people going in and doing a personalized assessment of AKI for those patients. So we'll see if using clinical decision support in that way might be helpful. I'm just going to spend the last 2 minutes of my time overtime to tell you a little bit about the work that we're doing in Alberta. So Matt, James, and I are co-leads on a couple of trials. We've named them Uptake, and we're using, again, clinical decision support within our electronic health record to improve processes of care for patients after AKI survivors at the time of discharge. And it's really based on this clinical prediction rule, which will risk stratifies patients based on the risk of CKD after acute kidney injury on the day of discharge. Very simple tool, published in JAMA in 2017. And I will just kind of skip to an overview of the two trials. One trial is to prevent hospital readmission using virtual hospitals and remote digital monitoring for patients at high risk. And the second trial is to reduce the risk of chronic kidney disease, major adverse kidney events at 1 year, and it really is by risk stratifying patients at the time of discharge and providing various levels of intensive intervention based on level of risk. So ideally, we're going from today's situation where, where patients, post-discharge care, we have a fairly low awareness of AKI, to a situation where we can tailor discharge care to the patient's individual needs. And with that, I will end. The answer to the question, I think, Ravi, is that we're not there yet. And I think part of that is just because we just don't have a good, I think these interventions will need to be tailored to things that are actually modifiable and specific etiologies of AKI. And that's, I think, where we're going to see success using these types of tools in the future. And with that, I will end. I'm sorry, I'm 2 minutes over.
Thank you so much for that, Nish. It's really exciting work, and I know we're all excited to hear about your results.